Welcome to Clinical Toxinology. Is it relevant to medical students? This clinical webinar series is now at Season 5, Episode 4. My name is Noor Azwani Shafika.
And my name is Balvinder Singh.
And my name is Marylis Leclerc.
And we'll be your moderators for this afternoon. It's a pleasure to have all of you joining us. This webinar is organized by the Department of Emergency Medicine Hospital Chancellor Tuanku Mukris. For your information, we also collaborated with several esteemed organizations to ensure the success of this webinar, namely Remote Evaluation Consultation Service, Malaysian Society of Toxinology, Special Interest Group in Clinical Toxinology, College of Emergency Physicians, Academy of Medicine Malaysia, Malaysia Biodiversity Information System, National Poison Center, University Science Malaysia, and Toxinology Education Resources and Development. Before we begin, here are a few housekeeping notes. Use your full name as your display name for identification. Kindly post your questions in the chat or Q&A box. They will be addressed during the discussion session. Please do not interrupt the discussion and wait for the moderator's cue before speaking. Recording, screenshots, or screen capturing are not allowed unless officially permitted by the organizer. Maintain professionalism and respectful communication at all times. For technical issues, please rejoin the meeting or inform the organizer via the chat. Please stay until the end and fill in the feedback form to receive your certificate of participation. Also, a gentle reminder that there will be a Kahoot quiz session at the end. Do stay tuned and stand a chance to win the grand prize, which will be awarded to the champion.
Now join me in welcoming Associate Professor Dr. Azlan Helmy Abdul-Samad, Assistant Dean of Entrepreneurship and Consultant Emergency Physician at Hospital Chancellor Tuanku Mukhris, to deliver the welcoming remarks for today's webinar. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh. And a very good evening to everyone. It's a good afternoon, actually, 3 o'clock in the afternoon. Thank you very much, our moderators, Chairperson for today, for the very kind welcome. So distinguished speakers, colleagues, dear students, it is my great pleasure to welcome all of you to Season 5, Episode 4. Just now, Azwani, when you mentioned about the Episode 4, it sounded like a Netflix series to me. So, Season 5, Episode 4 of our webinar series entitled Clinical Toxinology, Is it Relevant for Medical Students? Do I get it right, Azwani? That's the title, yeah? So, it's a very interesting topic. And first and foremost, I really would like to extend a warm welcome and sincere appreciation to our distinguished panelists from across the ASEAN region. So I was informed earlier that we have panelists from Singapore, Dr. Jonathan Tang. We have panelists from Vietnam, Dr. Vanessa, from the Philippines, Dr. Patrick, and from Brunei Darussalam, Dr. Hassan Adam Ishak. It perhaps is not, even though it's virtual, I think to all the panelists, selamat datang. Maybe to Dr. Vanessa, I would say Chào Mung. Is that correct, Dr. Vanessa? Chào Mung, Dr. Vanessa from Vietnam. To
Yes.
Patrick is Mali Gayang.
Yes, live welcome.
So I'm sorry if I butchered the pronunciation, but I would like to welcome Dr. Patrick to the virtual webinar as well. And of course, to Dr. Jonathan, welcome. And to students, when we hear the term clinical toxinology, many medical students may think that it's a very highly specialized field that's only relevant to certain group of specialized doctors. But the reality is different, because across our region, we know that with the globalization, with the climate change, the encounter with venomous snakes is perhaps going to be increasing in terms of frequencies. Not just snakes, jellyfish, insects, marine creatures, and other venomous animals remain important medical emergencies. And whether you're working in ED or primary care or rural health, or even during community service, that all of us in the future as doctors and future doctors will one day may encounter and face in situation where patient may suffer from any sort of degree of envenomation. And I think it is very crucial that at this point as medical student for you to learn the basics, being exposed to the principle of clinical toxinology. And it's not just about memorizing the type of venomous snakes or the type of different insects and whatnot, but more importantly is to recognize the life-threatening symptoms, signs, and what to manage, the principle of management. And even if at the end of the session you will not be able to memorize everything, it's okay because it's time to be exposed to understand the principle of it. And perhaps from that point onwards, you understand the importance of understanding how the pathophysiology of this condition. And ultimately, it is essential skill as doctors to be exposed on the principle of management of toxinology, particularly in this part of the world. I would like to encourage our students and participants to actively engage into the discussion, ask questions, because we have 4 panelists from different part of ASEAN who had uh, vast experience in managing this condition. So don't be shy to ask questions. And I would like to again, welcome all of you and enjoy the webinar, even though it's sort of raining outside in KL. But I hope that the discussion is going to be fruitful and you learn a great deal from this session. So without further ado, I welcome everyone for a very inspiring webinar, and thank you again for inviting me to be part of the session. So thank you. So I pass back to the organizing chairperson.
Thank you very much, Associate Professor Dr. Azlan, for your insightful and encouraging remarks. Your words inspire our journey towards becoming better clinicians. Now let's take a moment to introduce the theme behind today's webinar. This webinar is proudly organized by the Year 5 Emergency Medicine Posting Team under the guidance of Associate Professor Dr. Ahmad Khaldun Ismail, Consultant Emergency Physician at HCTM. We are truly grateful for his invaluable guidance and support in making this session possible. Now let's get to know our panelists for this webinar. Today, we are fortunate to have with us 4 experts who will help us explore this theme through real clinical cases. Let me introduce Dr. Jonathan Tang Ziying, Consultant, Emergency Medicine Department, National University Hospital, Singapore. Dr. Uyen V.Y. Duan, Toxic Disease Specialist at Pham Ngoc Thot University of Medicine, Ho Chi Minh City, Vietnam. Dr. Patrick Joseph Tiglao, Consultant, Emergency Medicine Department, University of the Philippines, Philippine General Hospital. And Dr. Hassan Adam, Emergency Physician, Hospital Raja Isteri Pangeran Anak Saleha, Brunei Darussalam. Thank you all for being here with us today. Now, Melis, I believe we can officially dive into the clinical toxinology. Can you please introduce to us what clinical toxinology is?
Clinical toxicology is a medical subspecialty concerned with the diagnosis, clinical assessment, and management of envenoming and poisoning caused by animals, plants, mushrooms, and bacterial toxins. So, what is a toxin? A toxin is a poisonous substance of biological origin produced by living organisms that can cause harmful physiological effects when introduced into a living organism. Since envenoming and poisoning was mentioned, what is the difference between those two? Envenoming refers to the active injection of venom into a human through a specialist delivery apparatus, such as fangs, stings, spines, or pneumasticis. Venom is typically introduced parenterally, for example subcutaneous, intramuscular, or intravascular, and contains biologically active toxin designed to immobilize prey or for defense. Poisoning, on the other hand, refers to toxic effects following exposure to a poison that is passively encountered without an injection mechanism. The toxin usually enters the body via ingestion, inhalation, or absorption through skin or mucosa.
Before we go further, I'd like to clarify an important concept that is often misunderstood: the difference between venomous and hazard level. An organism that is equipped with venom is called a venomous animal. What defines a venomous animal is not how dangerous it is to human, but the fact that it actively uses venom either for prey capture or defense. Now, the effect of venom on humans depends on several factors. Most importantly, it depends on the potency of the venom and the dose of venom that actually enters the body. Because of this, the clinical severity of envenoming can range widely, from potentially deadly, dangerous, not dangerous, and harmless. This leads to an important takeaway. An animal is either venomous or non venomous. There is no scientifically meaningful category in between. Terms such as highly venomous, moderately venomous, or mildly venomous animals are not accurate descriptors in toxinology. They tend to confuse the concept of venom delivery with clinical hazard. Instead, what we should be discussing is the hazard level to human, which is influenced by venom dose, route of exposure, and circumstances of the encounter, not whether the animal is more or less venomous. Before this webinar, we have conducted a survey among 41 final year medical students in the current emergency medicine posting at UKM to assess their awareness and confidence levels in clinical toxinology. Based on the survey, almost half of the respondents claim that they are aware of what clinical toxinology is about, which might have something to do with us joining episodes 1 to 3 conducted by our peers a few months ago.
In this section, we compared the responses from the previous sets of respondents for episodes 1, 2, and 3 with the current set of respondents for episode 4. For confidence in providing information on the appropriate safety and health-seeking behavior for toxin-related injuries, the majority of the current respondents reported feeling neutral about two components, namely various emergency services for toxin injuries and appropriate healthcare facilities after toxin injury. Compared to the previous episodes, respondents reported feeling unsure about various emergency services for toxin injuries component together with the role of the RECS component. On the other hand, the majority of the respondents from previous episodes reported feeling neutral about the appropriate healthcare facilities after toxin injury component. As for the toxin-related injuries as a medical emergency component, the majority of respondents remain neutral and confident about it. Next, for confidence in sharing knowledge on the appropriate safety and health-seeking behavior for toxin-related injuries, almost half of the respondents felt neutral about identifying the common signs and symptoms of toxin-related diseases, the appropriate first aid measures for acute exposure to natural toxins, and the various sources of natural toxins. However, respondents felt unsure about two other components, which are emergency hotlines, guidelines, and resources for managing toxin-related diseases, and appropriate antivenoms for treating envenomation in Malaysia. Looking at the previous episodes, the trend was quite similar, as these were also the components that respondents felt unsure about.
Lastly, for confidence level in providing instruction on the appropriate safety and health-seeking behavior for toxin-related injuries, the majority of respondents felt unsure about two components, which are administering the appropriate first aid for toxin-related injuries, emergency procedures in case of suspected toxin exposures. However, the two other components, namely identifying potential toxin injuries and obtaining important history detail following a toxin injury, and where the patient should be transported after a toxin injury, the majority of respondents felt neutral about them. From this survey, we can place greater emphasis on the role of various emergency resources and services, including RECS and toxin-related injuries, appropriate first aid measures for acute toxin-related injuries and subsequent important management steps, and appropriate antivenoms for treating envenomation in Malaysia during discussion of relevant cases.
In this webinar, we are going to discuss a few clinical cases with our expert panelists. For your information, these are the actual clinical cases in Malaysia that were referred in the past. Without further ado, let's begin our first case discussion.
So I will be starting with case 1. We have a 7-year-old Malay girl with no significant past medical history who presented after a suspected jellyfish sting while swimming at the beach in Pita, Sabah. So at 1200 hours, she developed sudden sharp pain after she was suddenly stung by a jellyfish over the bilateral upper limbs while swimming. Her mother described the appearance of the jellyfish as whitish in color with a tint of blue. There were no pictures of the jellyfish captured by the patient or her family members. She complained of pain over the bilateral upper limbs with sting marks and swelling associated with rapid breathing, as well as on and off productive cough. She had no fever, no gastrointestinal losses, and denies any sick contact. So before we proceed further, my first question for the panelists would be, based on this history, is there anything important that you feel is still missing or needs clarification? Would any of the panelists like to comment?
Good afternoon, everyone. Thank you for having us. I think based on this story, probably we will just need to clarify a bit of a history in terms of any kind of initial intervention being done in terms of like probably sometimes they just wash it by some solution, or might they scrape it off, or if there is any notice like kind of tentacles like kind of thing is stuck to the skin still at the time when they recognize there is pain on the limbs. So probably these are one of the things that we need to ask about, if there's any initial intervention being done on site from the family side, of course, or by bystanders. Yeah.
So to answer your question, Dr. Hassan, there was no initial management such as applying any vinegar or applying any other substance done by family members or bystanders. The patient was rushed to the hospital for medical treatment immediately. Would would the other panelists like to weigh in for the same question?
I think I would be interested to know, given that there's really rapid breathing, does the child look unwell? Is there any other systemic symptoms, like does she have vomiting, chest pain, any other things that would red flags that would really give you a lot more caution in terms of need a resuscitation beyond just localized stings?
That's a relevant point, Dr. Jonathan. Unfortunately, we don't have that information from this case.
Is there any picture of the injured site that we can view also? And what do you think of here it says bilateral upper limbs, right, was involved. So what do you think we should be also considering for such injury? Anybody? Patrick, our marine expert.
So I think if you try to look at the history of the patient having jellyfish sting and bilateral upper limbs with sting marks, if you were able to see the lesions in the upper limbs and how they look like, and was there any cyanosis noted, or even the temperature or the any warmth in the extremities, or any changes in the color of the nail beds, etc.
Yeah. Okay. So this is a 7-year-old child, right? A 7-year-old female. What do you think possible vitals that you will probably be seeing or anticipate to see in this child? Do you think, because she's complained of pain, right? But 7-year-old maybe a bit difficult to get the pain score. But I assume from the description here appears to be quite severe pain. Yeah. So what do you think? Vital signs wise, or is there any other thing that we want to look at? Somebody with jellyfish sting?
Probably still going to be tachycardic.
Mm.
Definitely going to be tachycardic, and probably the blood pressure might be a bit on the high side.
Mm-hmm.
Otherwise, we do expect that ventilation, respiration wise, it might be okay. But what we do anticipate is like just tachycardia.
Okay. So I would leave to our moderator. Maybe you can provide us what's the next step information for this patient.
Thank you, fellow panelists. So let's proceed with the physical examination findings and see how the case evolves. So upon arrival, she was alert, active, pink, and capillary refill time was less than 2 seconds. All peripheries were warm with palpable distal pulses of good volume, and she had no facial swelling, and her hydration status was good. So her vital signs that were documented: blood pressure 112/70 millimeters mercury, pulse rate 128 beats per minute, respiratory rate 32 breaths per minute, and oxygen saturation 92% under room air. So examination of her lungs revealed crepitations in the bilateral lungs with occasional bronchi. Meanwhile, the cardiovascular and abdominal examinations were unremarkable. And next slide, please. An examination of the upper limbs. As you can see, this is a picture of her left upper limb, noted to have multiple whip-like streaks, which were erythematous, swollen, soft, and tender. Next slide, please. And this is pictures of her right upper limb, noted similar whip-like streaks, multiple, and erythematous, swollen, soft, and tender. Otherwise, her range of motion was normal at the shoulder and elbow and the wrist. However, there was noted reduced range of motion at the fingers due to pain. Based on the panelists' opinion and on the information made available, do these findings likely point more towards local toxin effects or something more concerning?
Can we move to the vital signs just now? Yeah.
I think looking back into the vital signs, if you can see clearly the saturation a bit on the low side, and also she is like tachypnec, respiratory rate a bit on the high side, and of course the tachycardic. And examination-wise, there's crepitations in bilateral lungs. So I'm not sure whether during that sting events, whether or not she had any sort of like subimmersion, I mean associated subimmersion. Probably that also possible cause. But surely that low sats, it's a bit striking.
Okay. What do you think of the wound, Pat?
Yeah. Actually, upon seeing the lesion, it's pathognomonic of a box jellyfish sting. And given that the vital signs shows decrease in oxygen saturation and the physical findings of crepitations, this might be a systemic manifestation of the envenomation of a box jellyfish sting, which targets cardiopulmonary organs.
Yeah, I agree. What do you think, John?
Yeah, definitely concerning because it's not just local, swelling. We're talking about systemic envenomation now, and you need to resuscitate this child. So she needs high flow oxygen, and then we'll probably do a bedside echo to see what the heart function is.
Yes.
Yeah, to see whether there's any, myocardial impairment that can cause the pulmonary edema.
Yeah, you can do the ultrasound on the lungs as well, right? To see if there's any fluid collection as well. And also, I think the ECG will be happy. We'll be happy to see the ECG, but I don't know whether we have the ECG here. Yeah. What do you think, Vanessa? Do you have box jellyfish sting incident in Vietnam?
I'm sorry, I don't have experience on jellyfish. Yeah.
Okay,
So I
we'll
learned
pray for
from
you
all
to
of
have
you.
some. But I think, Jonathan, in Singapore, you have a new species of box jellyfish now.
Yeah,
Caronex
Stentosa.
belakang mati. Yeah. So
Yes.
I don't know. We'll see. Hoping for some cases to be to be discussed from
So, yeah.
Singapore.
Thankfully, yeah, very few. It's
Yeah.
very rare to get such severe box jellyfish envenomation, at least in Singapore. Yeah.
Yeah, so this is a typical also presentation for already systemic envenoming. But do you think the skin involvement on the limbs warrants for with the presentation? Do you think what can we do other than what you mentioned just now in terms of supporting with oxygen, considering during echo? Ultrasound. Is there any other interventions that we think may be warrant for
I
this child?
mean, certainly analgesia,
Okay,
antihistamines. But
agree.
I guess to check the if there's any vasospasm, I'll just feel the pulses. Like they said, the cap refill is less than 2 seconds.
Yeah, it's still
Um,
okay.
yeah. So I think doesn't need any vasodilators
Yeah.
at the moment.
Do you have any like warning ringing bell saying is this severe envenoming in terms of the skin involvement or not?
I'm not too familiar with the skin
Okay.
alone. I just go systemically.
Yeah, so meaning that we agree in toxicology and also toxinology dose dependent kind of thing. So you can look at the lesions are quite marked in terms of both limbs. So there's quite a lot of wide skin area involved, probably more than 5% or probably nearing to 10%. But what you can see here is not all in single lines. But in this particular picture here on the right side, on the left side, there's a kind of like a group of tentacles meshed together. So it's not just one, like on the left side here. On the right side, it's more like single lines of lesion, but on the left side, it's all single lines, right? But you see on the arm of the right forearm, elbow here, it's like a mesh of very concentrated, probably multi-layered of tentacles in contact in the area. So that will increase the so-called skin area, surface area that's involved with this tentacles contact to the patient. So we expect it's going to be a very high load of venom for this patient. Okay, can we move on? Or if any of the panelists have any questions you want to ask? No. Okay.
I just want to ask, yes, it looks quite extensive exposure. Was there any kind of residual tentacles was isolated during this incident? Yeah, it might not be change much in terms of management, but probably help with the identification probably.
To answer Dr. Hassan's question, there were no residual tentacles that were isolated. And for the panelist information, the percentage of body surface area affected for this patient is 18%. So
estimated as 18%, right?
Yes, Prof.
Okay.
So proceeding with the investigations done for the patient. Yep. So these are the blood investigations as well as the chest X-ray was done for this patient. With regards to ECG, ECG was done. However, I don't have the complete findings from the ECG. It's just what was documented was that there was no arrhythmia. So would the panelists like to comment regarding the results and the findings of these investigations?
I mean, looking at the labs, definitely the chest X-ray shows evidence of pulmonary edema. Patients in shock. You see the lactates up and the bicarbs only 13, so that could likely be cardiogenic or some form of hypoperfusion already.
What about the WBC?
Yeah, I guess this can be a marker, prognostic marker, I suppose. It's just very significant leukocytosis.
Yes.
Coax are also a little bit off now. So whether there's multi-system involvement beyond the cardiovascular system.
Yeah, we don't have. You can see the liver function. We don't know the level of normal levels for liver function yet. But this is the initial blood test, right? So it's just leukocytosis probably reflecting the systemic envenoming. Yeah. What do you think, Pat?
Yeah. I'm not sure about the range of the normal creatinine kinase, but it seems like it's elevated. So probably there's uh, a systemic manifestation, muscular um, muscular lysis, probably targeting the cardiac muscles.
Yeah, we don't have the
And
CK,
yeah,
but
yeah,
yeah, but the lactate is on the higher side for the
yeah,
child.
sorry.
Yeah. The venous blood gas doesn't show so much of is it compensation? Not yet. For the others, I don't see much that we can comment on. INR on the slightly from the laboratory abnormality, not the clinical abnormality. Yeah. So yeah. So but then the lungs, you can see in the chest X-ray is already marked. You can see the pulmonary edema. So that kind of coincide also with the physical finding earlier, right? See the SpO2 on the lowish side, and also having capitations. Okay, right. So what do we do? Ravinda, any progress from this?
Yes, Prof. So with regards to management done for the patient at hospital, the patient was given a nebulized Ventolin, intravenous hydrocortisone, intramuscular anti-tetanus toxoid, per oral paracetamol. She was put on a face mask with oxygen flow rate 5 liter per minute, and the wound was irrigated with vinegar. She was started on IV drip half saline and dextrose 5% at the rate of 46 cc's per hour, and she was subsequently transferred to a specialized hospital where 1 vial of box jellyfish antivenom was given. So, in view of the patient being given box jellyfish antivenom, do the panelists agree that this patient requires antivenom? And what are the indications of box jellyfish antivenom?
Yeah. Jonathan, you want to go first?
Well, I've never given it because Singapore doesn't stop box jellyfish antivenom. Given that the evidence is not that great. I mean, it's produced by Seqirus, right? So it's an Australian product. But I think I've seen it being used mainly in really either you're in cardiac arrest, or you are in extremis, so you're on the verge of collapse. Which I guess could be argued that this child could be deteriorating, and so it could be indicated if given early.
Yeah,
I wouldn't have given Ventolin. Might make the tachycardia worsen the heart
worse.
failure.
Mm. What about giving the steroid? Is it do you
Uh,
think will be helpful?
not in the immediate setting as well.
Yeah, because it doesn't show like an allergic reaction, right? Which we
Yeah.
think or a delayed kind of onset. So we don't think that it is going to be that helpful. But they have vinegar. What do you think is necessary at this stage to apply vinegar?
I think, yeah, by this stage, it's not going to make a difference because all the nematocysts will have been discharged. And
There's no tentacles to remove anyway, right?
yeah.
They didn't say any tentacles, so there's only function for the vinegar is to prevent secondary injury from in contact with the undischarged nematocysts from the tentacles. But
Yeah.
there's none, so I don't think there's a rule for vinegar here for this child.
I'm just curious to know because they say that it was transferred to another hospital. So
Yeah,
I guess it depends how long this transfer is going to be, and it shouldn't delay your immediate resuscitation for this
yeah,
child just for antivenom.
yeah. So I assume they have just put on the high flow mask, 5 liters. That's all. But no, I don't know whether the transfer is typically monitored closely. This place is located in Sabah, so we don't know how long the transfer is going to be. Probably 1 hour or so to another hospital, another specialist hospital. But the box jellyfish antivenom was stopped in that hospital. I assume probably 1 to 3 vials. But yes, I would argue that yeah, I think I would say there is an indication. There are 3 levels that we look at in giving box jellyfish antivenom. Is just it for the pain itself, or is it now we have impending doom kind of scenario where the airway is going to be compromised? and then the third one is maybe the third one is really in already in resuscitation, in probably cardiac arrest, that we probably intubate first, and then we give the antivenom after that. So the amount of antivenom also will vary. So just for the pain, maybe just one vial, but in the second part where involving airway, cardiorespiratory compromise, then we probably give 2 vials and 3 vials in the state of already cardiac arrest. Okay, so the amount of antivenom, I don't know what is the logic behind that, but that's the guideline that we got from Australia for using the antivenom for box jellyfish. Okay, so Pat, what do you think? Have you given a box jellyfish antivenom in or any experience?
Yeah, actually we have no box jellyfish antivirus, but we have the similar cases in the Philippines where the patient would have systemic manifestations beginning with pulmonary edema. So I think the most important thing is to secure the airway and then monitor the patient. Also, if still advisable to immerse the patient in hot water immersion. So you would have to clear out other possible nematocysts that haven't yet been penetrated in the skin, and also monitoring. Usually the cardiac manifestation is one of the most common cause of the death of patients. So
Do
monitoring
you think the
and
hot water immersion will be having any significant what do you call effect for this patient at this stage?
for this case, I think depends on the timing. If this were maybe an hour after, it wouldn't probably have more effect, but more effect on the as an analgesia on the part of the pain of the patient. Most of our cases coming in like 1 hour or 2 hours after, we still do hot water immersion, and they still have had comfort with hot water immersion in terms of the pain scale. So, well, depends on the current pain scale of the patient, and if the analgesia would be of that effect in this patient.
I would say in terms of pain score, the patient certainly needs optimizing of the analgesia. Just giving a PCM paracetamol will probably be suboptimal in controlling pain for this patient, I think. You may do multimodal for this child. Yeah. Okay. So, yeah, back to you, Ravinda.
Right. So for progress post after the antivenom was given, the patient did not develop any reaction towards it, and she's recovering well and is planned to be transferred to another specialized hospital for monitoring of the cellulitis in her bilateral upper limbs. And next slide, please. So these are pictures of her bilateral upper limbs after the antivenom was administered. Next slide.
How many days after?
Roughly 1 week, Prof.
1 week after, okay.
And this is the patient's chest x-ray 1 week after treatment, showing clear lung fields.
Okay, that's remarkable recovery, I think. What about the, so the child was never intubated and ventilated, right?
No, Prof.
Okay, so I don't know. What do you think, John?
I don't know. It depends whether did you see a dramatic improvement after the box jellyfish antivenom? Did you see the ventilation requirements come down, the child look better?
Yeah, so those things are not transpired here. So maybe it was a lapse in following up the patient through REX. They just report when the child is already okay. So but we assume that there's no escalation of therapy or treatment wise, nor repeated dose of antivenom after the first dose. So we assume the child was recuperating well after, and there's no requirement for emergency airway as well. So so the question is, can we say that the antivenom works for this child? That's I think that's the
Yeah.
The mysterious question that it always comes to mind. And because if we are not careful, we will probably jump to the conclusion too early and decide, oh, this is a nice case to prove that box jellyfish antivenom works, and publish a paper, right? Publish a case report. That might get you into a hot soup. I think if you're not in it, we can report, but we not be saying it's a conclusive evidence, right? That the box jellyfish antivenom really works, because one, I think, is already quite delayed. But meaning that as we know, the venom from box jellyfish can be quite transient. So the damage was already done earlier, but does the antivenom then reverse the symptoms, or does it stop things from becoming worse, or does it really involve with, for example, some people, some of the recommended reason for the box jellyfish is to see the wound. So the wound seems to be healing quite rapidly and well as well. Does the child have any? Was the child given any antibiotics throughout the stay, Ravinda?
It was not documented, Prof.
Or not documented? Okay, so very unlikely as well that antibiotics was given. But then you can see the superficial partial thickness kind of feature from the middle picture there. You can see the underlying skin is pink. Yeah, so this kind of a partial thickness, sort of like a destruction of the skin from the wound, from the sting. Okay. Yeah.
But
So
I
do
think
we?
if antivenom were to make a
Yes.
difference, it really be on scene and as early as possible within
Yes,
the hour.
exactly. This one
Because
is
most
already
of the
transferred, right?
deaths,
Yeah,
once you're transferred, then
it takes
you
quite a
know it's
while.
a bit debatable, but
Yeah.
most of the deaths all occur pre-hospital.
Yes, true. Yeah. So, but we don't have a box jellyfish antivenom at the sea and by the sea, right? So we don't know how fast we can give. So the child arrived already quite in a hospital. But I think what is commendable is I think the emergency approach throughout the whole kind of incident. From even a smaller hospital, they are able to provide rather, I think, appropriate treatment, even though they don't have antivenom, but manage to maintain vitals and also pain, and then proceed to the secondary hospital. And they managed to manage the child well, apparently, without any issues with intubation and ventilation. And you can see the lungs was rather much better. So yeah. Okay, so I think all in all is good. What do you think of the antivenom? Probably questionable, I would say. But they give only one, so only God knows, I think. And there's no recurrence or escalation of the issue, right? What do you think, Hassan? If this happened in
Luckily,
Brunei,
throughout my 10 years, I haven't seen any case of jellyfish exposure
you're very
so far.
very close to Sabah. You're just next door.
Yes, but I think the exposure here is like quite almost zero. And we are lucky. But Prof, I just want to have a bit of a lingering question regarding the cardiotoxicity effects of the jellyfish stings.
Box jellyfish. Box jellyfish.
Yes, sorry, box jellyfish. Is it direct cardio depressing effects, or is like just lead to preferential kind of pulmonary capillary leakage?
We are not sure exactly. The toxins are meant to be like a pore forming. It causes a destruction of the cell forming pore, and that I'm not sure whether it's directly to the heart or any other muscles. So the study did not suggest what you call typically cardiotoxic per se. But then the injury that it causes may actually cause triggering of cardiac depression leading up to the APO, and the APO itself may be because of the basement membrane in the lungs, in the capillaries, causing leakage, and therefore secondary, the features that we see in this child's X-ray. So I'm not sure. So if I'm just wondering if, let's say, if it's really destruction, will the child recover within just 1 week from this?
Yes, exactly.
So will it kind of, I would assume that it will be taking longer for physical injury, direct physical injury like that, to recover,
Correct.
longer. So I'm not sure whether that is a kind of a transient issue of capillary leakage itself, or is actually a real destruction of the cell, because
Right.
the one that we know that was told to us is that it's a pore forming toxin. So whatever that means. John, you from your reading, what do you think?
I mean, there are some animal studies where they inject the box jellyfish venom into like hearts, right? And you can see the heart just completely turn white. It goes into a
Yes,
tetanic spasm. And
yes,
so more or less you just completely turn asystolic. So it's not really a VF kind of shockable rhythm, but you
yeah,
really go asystole.
yeah. It's kind of a depressive kind of a feature as well, right? It just stops. Yeah,
Mm.
yeah. Okay.
Can
All
I
right.
can
Thank
I
you.
have a question?
Yes. Where are you?
Uh,
Can't see you. Okay.
I just because I don't have experience about the box jellyfish antivenom, so I just want to ask about, so for this box jellyfish antivenom we can use for all kind of jellyfish or box jellyfish or not, or is it like snake? So every different type of the antivenom so will be different or not? Or we
Yeah.
just use that one for all kind of jellyfish?
No. It's not a polyvalent box jellyfish. Yeah, because it's derived from the Chironex bacteria. So it's supposedly more for the Chironex species, and I think it's derived from sheep. I think. And in Japan, there's another box jellyfish called Chironex Yamaguchi, and they did, from our contacts in Japan, they did show us a paper uh, measuring the efficacy or efficacy of the box jellyfish from antivenom from Australia to the venom of the box jellyfish in Japan, and there appears to be a cross neutralization feature for this antivenom. So that's why we are using it in Malaysia, because we know we don't have Chironex fleckeri, the ones from Australia, but we do have the Chironex Yamaguchi, and I think it transferred to the Philippines as well, right? So on the north part from the Philippine Islands down to Sabah coast. So those are the sort of like Yamaguchi species in the area. So that's the reason why we say, okay, since we don't have Freckerai, but we have Yamaguchi, why not just stock some box jellyfish antivenom? And we've been using it quite a few times already. Some of them are quite positive outcome, like this case, and also there were a child before as well. Yeah, but I wouldn't say that it proves 100% that it really works in envenomation in Malaysia, but we still stock them. Okay, now we also stocking it in the West Coast, in Penang, and also in Langkawi. And we had cases of box jellyfish envenomation in these islands. Okay, right.
All right. So my last question to the panel would be, what is your advice to the parents before discharging this patient? Would any of the panelists like to answer this question?
Beth?
I think what's the advice for the parents would be to monitor the patient's possible after effects. So although we know that the patient already recuperated from the box jellyfish envenomation, we don't know if there are adverse reactions from the box jellyfish antivenom, or there may be um, after effects of the envenomation itself. So try to look at the lesions if there will be cellulitis or probably secondary infections, and monitoring of the patient if the patient would feel unwell actually. So um, patient may opt to have observation and follow up with the attending physician.
Okay.
Actually,
I would say
yeah.
cover up
The lesions.
if you want to go back
Actually,
into the water.
yeah. Actually, there's also I also have some questions if Malaysia do have management for those lesions, like the marks, because oftentimes these marks becomes uh, trauma to the patients, that reminding them that they had box jellyfish, and it stays longer, like months to years. So do you have any uh,
We
after
we
management? Yeah.
Yeah, we would say just the outpatient for the wound management. Of course, if there's any dressing is required, secondary infection, as you mentioned just now, needs to be treated. Other than that, there's because it's a partial thickness kind of thing. It's just aware of, and luckily so far we don't have any patient here with keloid for this injuries so far that we know of. So all kind of over time it will what you call the melanistic feature will appear, becomes darker over time. So but it's a child, so child is a bit more plastic in their healing. So hopefully it will not be a big scar or what do you call obvious scar on the skin as the child grows up. Yeah. But you are right. Wound care should be optimized for all patients, even though they discharge well like this. Yeah. Jonathan, what do you think of the wound care? Any input?
No, I mean we do see some who come after swimming in Malaysia waters and they come back a few days later, complaining about some delayed effects. But we haven't really followed them up, in the hospital.
Yeah.
So I'm not sure.
Yeah.
But I guess like any other pigmentation, it should fade gradually.
Yeah. Some will develop these eruptions on the skin, but those are the kind of a slightly different type of jellyfish as well. And it's self-limiting as well. So over time, it will resolve by itself, but it takes time. And maybe treatment of steroids, topical, and antihistamines later on might be helpful in terms of controlling the symptoms. Yeah. Okay. Next.
Okay, so before proceeding with the second case, are there any questions from the floor? Does any students want to ask any questions?
Yeah, please forward your question in the Q&A box.
Hi, Prof, and to the panelists, can I ask a question?
Yeah, go ahead.
Okay, so my question is about the breathing part of this patient. Just looking at the picture, 7-year-old girl having APO and desaturating. If there's available resources, do we need to have early ventilator support for this patient because she's just given high flow mask, which I think might be not adequate for this patient. And another question is, if we do have the pneumatocytes, from my understanding, do we need to send them for lab for any microscopy examination or further identifying of the specific species? Is there a need for that? Okay, thank you.
Okay, Pat?
Actually, upon seeing the patient's vital signs and the X-ray of the patient, ideally you would have to protect the airway. So looking at if the patient would have progression of the pulmonary edema, if it's too late to intubate the patient, it would have probably better to early intubation just to protect the area of the patient, granting that the patient is already having pulmonary edema on the onset. Then second, dermatocysts. Actually, in the Philippines, we hardly have on the setting of getting the pneumatosis because already the patient already had proper manage already the patient by cleaning the wound, etc. But it would be beneficial if the pneumatosis were uh, had you had the pneumatosis sample just to know what kind of jellyfish the patient had stung the patient. But probably I would prioritize first how to manage the patient rather than knowing what kind of jellyfish, because
Well,
granting that the patient had the marks of uh, box jellyfish, so uh, without having the box jellyfish antivenom, I would prioritize the ABCD first.
yeah, I agree. I mean, there's no point
Yeah.
of the skin test anymore because it's very typical, and patient has already sign symptoms, so we know it's a Karanak species. From that waters, we know it's Yamaguchi, but it's not confirmed diagnosis, but we can infer to this particular species for the injury the child is having. Okay. So probably as I'm just being a devil advocate here, maybe then that shows the child was not being intubated, but they were using box jellyfish antivenom. Does it mean the box jellyfish antivenom works? The airway protection seems as in you don't have to do airway protection for this child. They just gave box jellyfish antivenom, you know. So I mean, just as a kind of devil advocate there for box jellyfish. But anyway, lucky the child was not intubated, and they gave one before that as well. Okay, so we move on, shall we?
Thank you to all panelists for the insightful sharing. We'll now proceed with the second case.
So moving on to our second case. Our patient, a 30-year-old female who works as a vet, came in with alleged unidentified snakebite. She was walking on flat ground near Putrajaya Lake at that time and noticed the snake glided on her left leg. The pain score was 0. She sustained tingling sensation over the bite site with no weakness or other complaints at that moment. No initial management or intervention was done. She arrived to the ED approximately 1 hour later. To our panelists, any additional information that you need based on this very short and concise history?
No, I mean, it sounds like, she's fairly asymptomatic, other than that mild discomfort over the bite side. So we probably need to get her to describe the snake. If possible, show a picture. At least we can have something to work with to help with the risk assessment.
No, she's a vet. She's a vet, Jonathan. Don't underestimate vets.
I don't know whether vets look after maybe a very, very small number of snakes, suppose, if she works in the zoo.
No, she's a private practice, I think. Yeah.
Okay.
Yeah. So I agree. And so does she have any evidence of the culprit?
So this is the picture captured by the patient, and these are the only 2 pictures sent and provided to the medical officers in the emergency department. So maybe based on this picture, what species do you think this could be?
It's a snake.
Looks like a brown snake. It's very hard to see the features. But I guess a king cobra is possible, but it looks a bit small. I mean, hard
Very
to.
interesting king cobra in Singapore. Okay. Patrick? No, just a snake. Vanessa, do you have this snake in Vietnam? Snake with the red tail, huh? Is it truly red tail?
The red is the horn body of the snake.
I don't know. It's in the picture there. That's taken by the vet.
Well, it's difficult.
Yeah, okay. It's difficult, right? Okay. It looks like the head is like hooding a bit, right? Going up a bit. Okay. Can we see then what the patient was treated with in the beginning on arrival? Okay, upon arrival.
So, upon arrival, she complained of weakness over left upper and left lower limb alongside the tingling sensation over the right side. She also complained of diplopia. However, there was no ophthalmoplegia or ptosis. On general examination, she was alert and not in respiratory distress. Her vital signs were stable, and examination of the systems were unremarkable. And upon examination of the left upper and lower limb, there was no wound or bleeding, no swelling or tissue necrosis noted. The capillary refill time was less than 2 seconds over all fingers and toes. However, the power of left upper limb was 305 and the power of left lower limb was 205. The sensation remained intact. So, questions to the panelists at this juncture, what are your opinions or differential diagnosis?
Hassan?
From my side, based on history and based on the picture, probably I'm not sure about the picture, but from the clinical scenario, it might fit into something, might have a kind of neurotoxicity. But
Okay.
the symptoms on like kind of one side, left upper and left lower, that is a bit off. Though the diplopia might explain that, but I'm not sure about the left upper and lower tingling sensation.
What is the issue there?
Because this is like a kind of left upper and left lower tingling sensation. So it's
No, this is the power. The power is affected.
Oh yeah, the weakness on the left upper and lower. That's, to me, it sounds, I'm not quite familiar with these kind of symptoms, because if there is a weakness, has to be there, should be sort of a kind of descending kind of pattern rather than to be unilateral.
So bilateral, you're saying?
Yeah.
Bilateral weakness, if you are suspecting systemic envenoming, right?
That's what I do expect. Probably I'm wrong.
Yeah, okay. That's why we have the discussion here. Jonathan?
Yeah.
What's your take?
Yeah, I guess the diplopia is of a concern. It's still fairly early post-bite, 1 hour plus, but you could potentially get early onset of some neurotoxic symptoms.
Since King Cobra is already in your mind just now, you're thinking of it?
Yeah,
King Cobra. Yeah, what do
I
you
guess
think?
one of the 8 snakes that we worry about in Singapore. But yeah, I mean the weakness, I'm not too convinced as well whether it seems too rapid, and whether it's functional or not. I probably need to monitor and see what the progression is like.
Okay, can you go back one slide? What is the pain score?
The pain score was 0 and it was 0 all the time.
Okay, so next slide. Yeah. So do you think that pain score 0, unilateral weakness, very strange, no early sign of ptosis or diplopia suggesting neurotoxicity, but so okay, so this is what the patient presented, and as a doctor, let's keep this in mind. Can we then move to the next slide?
So moving on to the blood investigations. So several investigations were taken. Full blood count shows fairly normal results. The renal profile, urea 4.8, creatinine 70, sodium and potassium are normal. And CK was taken, it was 183 with CRP 0.4. At that time, ECG was done and it showed sinus rhythm.
Okay, so go to the next page. Okay, so back to this pictures with all the presentation just now. Are you going to start antivenom? What do you think? This is very Patrick. You can't escape this one.
For this case, what's weird is because of the one-sided weakness. So, and there's no pain on the bite side. So, thinking about it, it can be other than snakebite, it can be another medical condition. So, if I were the doctor, I would, since the patient is still stable, I would do probably a scan for this patient, CT scan, just to note whether the patient is having a stroke rather than a snakebite envenomation.
Very good, very good. Okay, so it could be a an incidental finding, right? But kind of a feature somebody might have a TIA or something like that. But she doesn't have any slurred speech. Does she have a slurred speech?
No, she does not
No,
have
right?
any slurred
And there's not
speech.
any facial weakness. The typical that we see when we assess someone with stroke was not there, except for the weakness on the upper limb and lower limb actually. Okay, so what do we have next? Be mindful, she's a vet, so don't play. So next.
So moving on to the next slide, as claimed by the patient, the snake was described to be blue in color with red tail, and this was the image she showed to the medical officer obtained from the internet. So my
Okay.
question is, if the patient herself is a vet, would this increase your confidence in the species identification?
Jonathan, yes, now, not
Oh,
king cobra.
Snake.
well,
How are you going to deal with this
Malayan.
patient?
Well, you can't dismiss her concerns, right? You still have to say she's also a professional as well.
Yeah.
Though, of course, vets, you're not herpetologists, so
Okay.
right, unless she starts specializes in snakes. I mean, the Malayan blue coral snake is very distinct, right? It's very
Yeah.
obviously,
Yeah.
but I don't see any hint of blue. If you're certain that that is the snake that bit her, and that's
And
based on that
the
photo.
head is not red as well, right?
Yeah, it's not
Yeah, the head is
it's
only the tail part, and that could be something else. It could be a reflection from a camera or lighting or something.
yeah. So I
So
don't think we probably have to convince her that it's unlikely.
yeah, how
Uh,
do you convince her? That's the question. She's a vet. You're just a doctor. You don't see. She saw more animals than you do, and so it's going to be tough, dealing with this kind of patient. And then she was demanding that this is the adamant that this is the feature, and she said she has all the sign symptoms. So what do we do next, right? So yeah,
Guess you could send it on to a professional, like
yeah,
Rex or like the zoo or
yeah,
someone who
yeah,
can verify
yeah.
the
Okay,
and
Rex would say, "I agree with you, doctor. I don't think this is a venomous snake." But I do agree that you require maybe further investigation for the CT scan to see whether there's any sign of cerebral or central problems. Okay, stroke, for example. Okay, right. So we take that in mind. So let's see what happens.
So at this point, Rex was referred, and based on this picture and based on Rex input, neither the head or tail is red colored, and eyes are located at top of the head, and these are the features of Hypsiscopus plumbea. So
Not king
assuming,
cobra.
yeah, assuming the
So
snake indeed Hypsiscopus plumbea, how would you explain the patient's neurological findings earlier on?
interesting. Vanessa, what do you think? Patient complain all these features of vital sign of bilateral unilateral weakness. I think that's all, right?
Yeah,
So how do you explain possibility? It's a non-venomous snake. Rex has already confirmed. But how do you explain the sign symptoms that she has? Hassan?
It's very difficult to explain, Prof, but having she is a vet and definitely, as you have said, she knows lots of kind of snakes more than us, but based on the clinical scenario, based on the proven picture identification that this is not non-poisonous, I think this patient just need to be consulted, and probably whatever symptom that she has, if the CT scan reported to be normal, or probably the best kind of
Okay, so
investigative modality are going to be MRI, because MRI are
okay,
going to be totally conclusive.
okay.
And
So we are
if
not that affluent, so we just stuck with the CT scan. So can we see the CT scan? What is there any results for the CT scan?
Yes, so for the patient's progress, her power remained the same with diplopia still present. CT brain was done and it was normal with an IHSS score of 5. She subsequently developed transient episode of hypotension and bradycardia, which improved with fluid bolus. So does this progression increase your suspicion for other things going on? And would you consider antivenom at this point?
So, I'm a vet. I know what's next. I claim to know what's next. So, what do you think, Jonathan? Antivenom indicated?
I guess we've already kind of identified it, and there's no role for antivenom.
Yeah, but doctor, I'm a vet. I want the antivenom. How would you respond to that?
I guess you won't be, I mean, giving patients treatment that is not medically indicated in any case. So they can't force your hand that way. You just need to explain your rationale, weigh the risks and benefits. The antivenom is not completely, safe. There are some adverse effects, the risk of anaphylaxis and then delayed serum sickness. And so
Yeah.
we don't give it, freely.
Yeah, you're not going to give it like in Singapore. Okay, so what about you, pet? And she said, I'm a vet. My husband is a senator. I want the antivenom. How would you react to that
Yeah.
kind of statement?
I would say we don't have
Is there such a thing of
antivenom.
patient like this? Very demanding.
Well, if this is the case, well, depends on the snake species that was identified, and
Yeah.
we only have one antivenom for available. So for that case, we don't have, so we cannot give any of the antivenom. So I'll just do supportive management for this case.
I will call my husband and talk to you.
Okay. We can talk and then ask the senator to provide a policy on snake bite program. So all of the patients in the Philippines would have adequate antivenom.
But obviously you're going to stand you're not going to give for this patient, right? So
Yes, I will not.
identified non-venomous snake. It's a water snake. Histriscopus plumbea is a water snake, so it's not venomous at all. And you can see the sign symptom, no pain. So there's no local envenoming to suggest any neurotoxic venom. Plus, there's no typical envenoming systemic from envenom. So let's see what happens.
So after evaluation by the medical team, with nature of ascending weakness, stroke was unlikely. Hence, the consultants then decided to give her the neuropolyvalent antivenom. So after 5 vials of antivenom, her symptoms actually improved. Power of left upper and left lower limb improved to 4/5. The diplopia resolved, and she was hemodynamically stable. And after completion of all the vials, patient regained normal neurological function with no complications developed. And she was then discharged.
I'll see you in court, doctor. You did not give me early enough antivenom. So how do you fight now? How do you to suggest that this apparently, and the doctor was so afraid, the medical was so afraid they give the antivenom, and subsequently everything turns rosy well. So how how do we stand our ground in this type of scenario?
I guess
This is a real case, okay?
to the med students, it's physiologically implausible, right? Because you can't, it's not like a hemotoxic kind of thing that takes time. But even with neurotoxic, it takes days to gradually recover, or at least hours, not so rapid recovery of your weakness. If you do have pre-synaptic or post-synaptic neuromuscular junction damage, then it would take a lot more time.
Yeah, but then we already agree that this is not. So she was looking at that blue-colored snake, so fixed in mind that she think that that is the cause of the envenoming, but which is against the expert consultation, saying it's just Hypsiscopus plumbea. But then she came back with say, "Oh, everything improved after giving me the antivenom, doctor." So does this antivenom works, or the consultants feel better? What if she did not work? If it did not work, right? So anyway, this is the conundrum that we face in such managing such case. Okay, so obviously it's a false flag for many things here, starting from being a vet. Okay. So that kind of shift the decision making dynamics. Sometimes we are very forced to, our hands are pulled to do things to administer stuff which are not relevant or not indicated, and therefore some other consults which are the experts, the recs already saying it's not not a venomous snake. You did the CT scan, already normal, no bleeding, no sign of stroke. You did already the physical examination. It doesn't correspond to the neurotoxic of systemic envenoming. No pain as well. Okay, if you're suspecting a cobra or thing, it might be painful. So yeah, so this is a waste of resources. I think you give the antivenom, which is a wrong decision. If you just wait for a while, probably she will actually recover herself. But I would suspect there's an element of anxiety as well. That could actually trigger all these kind of features of hyperventilation, possible leading to all this paresthesia that was mentioned before. It's very very what we call non-specific features of hyperventilation, right? Let me see. Okay, anyway. Yeah. Anyway, so what's the progress after this?
So as
Anything
we
else?
agreed, there is no indication for antivenom in this patient. It is because the image resembles a non-venomous Hypsiscopus plumbea, and the clinical signs and symptoms of left hemiparesis without ptosis is very unusual for neurotoxic snakebite envenoming that clinically will actually cause generalized flaccid paralysis. And for this patient, she has no pain with no local envenoming effect, makes Najospecies envenoming unlikely. So in this case, other causes of left hemiparesis and diplopia in a young lady without myocardial infarction should actually be investigated. Next.
Yeah.
So the revised diagnosis that was suggested is that patient is bitten by Hypsiscopus plumbea and unrelated neurological symptoms and signs subject to further investigations. So before
Yeah,
we proceed.
Yeah, do you agree, Jonathan?
Yeah, absolutely. I am not convinced at all.
Absolutely. Very expensive case if this goes to court. Anyway. All right. So Hassan, you agree?
I think, Prof, to me, for this, yes, it's quite complicated, not a straightforward case. And still, I do feel that what if this lady, after we gave the antivenom, is still the unilateral symptoms is still there?
Yeah, so that's why that's the number 2.
That's number 2. So
Yeah.
that's why my point is, having done the CT brain might not be conclusive. So I do feel that, and I do still feel that the MRI should have been done.
Yeah, but she recovered.
Recovered because of the probably placebo effect of that
So that's a placebo.
unindicated kind of.
That's the
Yeah.
magic of antivenom. There's a real
Correct.
effect and there's a placebo effect. Okay.
Correct.
So
Yeah, but
that could
quite
be an
complicated.
outlier on itself. So
Yeah.
anyway, yeah. Yeah, it's a difficult choice. If you are put into the same shoe as these doctors managing this case, how would you proceed? Are you going to go for more and more expensive therapy, treatment, and so on, where there's no clear indication? But what is certainly clear is that snake is not venomous snake. So you cannot rely and fall back onto the snake possibility it is a venomous snake. It is already not venomous snake. So that's really definitely out of the question. So the rest is going to be other investigation related to any sign symptom that she might have, including possible she is already very anxious. Okay. Yeah. Okay. So next.
So next we are moving on with the next case, which is a 55-year-old Malayman who presented in a late snake bite. The incident occurred at 16:45 p.m. and we arrived at the hospital about 15 minutes later. The bite happened at his home while he was gardening. He sustained a single bite to the dorsum of his left second toe. He attempted to squeeze blood out of the bite site himself and was brought in by a family member. His pain was 6 out of 10 at the time of the bite, improving to 4 on arrival and later 3. So here we have a photo taken at the scene, so we can see the gardening debris and his sandal, giving us a sense of the environment he was working in. With a closer picture of the snake itself. So for the vital signs on his arrival, heart rate was 107, blood pressure 143/95, respiratory rate 18, temperature 37, and SpO2 99%. The patient was alert, conscious, and oriented with a full GCS. Peripheral perfusion was good, warm peripheries, cap refill under 2 seconds, and he was pink. On systemic examination, the lungs were clear, the vascular exam was normal, and the abdomen was soft and non-tender. His blood showed a normal FBC with the renal profile with sodium about 141, potassium 388, 367, and creatinine 120, though we have no baseline for comparison. Liver function was normal and coagulation was normal with an ENR of 1.01. So here we have the clinical photos of the foot taken on the day of admissions. So what can we see on those pictures?
Okay, so anybody would like to identify the snake, I think? Have a look at the snake. So there's puncture wound there, you can see. Yeah. So, Jonathan?
Yeah,
Very
so
close
I mean, it looks like arboreal snake because he's gardening, right?
Okay.
So he cut the branches and it dropped on him. It bit him on the
Because the snake is green in color.
fits in with
Okay, so
the
what?
trees. But it's got a triangular head, so it looks like a viper.
Yeah, okay.
And so it's probably one of the type of pit vipers, and not sure which one, whether it's a cute
Okay.
pit viper or I'm not
Okay.
sure. One of the Tropidolemus
Yeah.
species.
Yeah, I agree. Male or female?
Well, males are smaller than females. So if I were to
Okay.
guess, probably male, but
Yeah, because the shoe size is, smaller than the shoe size. Okay. What about you, Pat? You have also in
Yes,
Philippines this species.
yeah, same. So it's
This genus, different species,
yes,
right?
yeah, different species, but
Mm.
I mean, most of them have similar complications. So for this case, identifying the snake would lead you to the management of this patient. So let's see.
Okay, let's see. What should we do? This is a pit viper. It's a Tropidolemus, as Jonathan say. I can tell you that this is a female, a very young female, Tropidolemus. From the coloration and also the evolution of the color on the back, becoming a bit darker and darker green. So, plus it is in Peninsular Malaysia, so it's a Tropidolemus vaglari. If it is in Borneo, Hassan in Brunei, this would be Tropidolemus subannulatus. Another key feature that we can see from here, the tail, as you can see the tail there, the black stub at the end there. Yeah, it's very stocky. So that's another sign it's a female. It's a male, will be a bit more longish tail. All right. So this is a young juvenile female, teenager female Tropidolemus vaglari. Okay. Okay, so we have identified the species. So let's see what's going on. The vital signs was unremarkable. The pain score was only 4/10. Vitals also normal. No active bleeding from the puncture wound, right? Melis, can we see the wound? Yeah. Okay. Can you zoom in to one? There's 2 puncture marks there, is it?
So on local
Or is it?
examination, there was a clear mark over the dorsum of the left second toe with no active bleeding. There was erythema and swelling extending up to the midfoot, but no dermonecrosis or blistering. And the capillary refill was under 2 seconds, and all toes, movements, and cessation were intact, and there was no palpable lymph nodes, and
Okay.
pulses were palpable throughout.
So what's the question now? So what do we do next? Right?
Yes. So the
Okay.
diagnosis was Tropidolaemus bagleri-bite with local envenomation, which was initially documented as male, but on closer identification, it was actually a young female.
Okay, so these are the questions that we think that needs to be clarified.
Yes, so
Okay.
the questions for the procedures. So we wanted to know how exactly did he get bitten? So if he stepped on the snake, what happened to the snake after? And is the swelling painful or progressing proximally since the arrival? And last, when was his last tetanus vaccination?
Okay, go on.
So the mechanism, the patient was clearing leaves and branches in a bushy area and suddenly felt a bite on his left second toe. He's unsure whether he stepped on the snake. The snake was pushed into a drain with a broom and escaped, and his last tetanus vaccination was approximately 15 years ago, and there was no progressive swelling after arrival.
All right.
So here we have the plan of the ED. So it was an hourly snakebite charting with LPP monitoring, repeating the FBC and coagulation profile and CK after 6 hours, referring to the medical team and observing for any worsening of local envenomation. So now my question is, what should we watch for envenoming syndrome?
Okay, so we think this is possible just local envenomation, right?
Yes.
Okay. Hassan, what do you think for this species? Do we need to have an extensive observation?
Since we are dealing with the pet viper, I think yes, clinically stable parameters looks okay, but surely she need to have extended observation in terms of like progression of the swelling, in terms of how the other blood parameters will looks like probably few hours down the road. And we will also look and observe for any sign or symptoms of anaphylaxis, because sometimes they might have anaphylaxis as a part of the bite itself. But what I would suggest to be observed for a few hours.
Yeah, you
It's
have
not
this
a day.
case in Brunei recently, right? Last year, if I'm not mistaken, I posted.
Yes, correct, correct.
Yeah, so that one was an adult female, a semi-adult actually, but that was Tropidolaemus subannulatus. So the question is, for this particular species, do you expect patients to go into coagulopathy?
Theoretically, yes. But for that specific patient, last year, well, yes, he was admitted overnight, and next day by noon or PM time, he was discharged. And all the
No
way
coagulopathy.
coagulopathy profile is okay.
Yeah, we don't. What do you think, Pat? What about Tropidolaemus bite in Philippines?
Yeah,
Do
actually,
you?
we also have Tropidolaemus subannulatus in the Philippines. Most of these bites are just benign bites, so we just do monitoring. It would have gradual swelling, but it will eventually regress, and then patients' coagulation studies would not be that high. So usually we just do proper monitoring and supportive management.
Vanessa, do you have this species in Vietnam? Tropidolaemus? temple pit viper. Vanessa? Disappeared. Anyway, Jonathan, what about Singapore?
Yeah, we have Wagler's pit viper. If you wanted to be bitten by any pit viper, I suppose you choose the Wagler
Yes.
because they're the most benign one. So
Yes.
I will probably observe and discharge in
Yeah.
6 hours.
I
Yeah,
agree.
there's no risk of coagulopathy.
No, there isn't. So we did a study also on the Tropidolemus species in Malaysia, both in Sabah and Sarawak, and also Peninsula. The two species of Tropidolemus, and we found that all the bite cases did not reveal any issue or indication for antivenom at all. Did not go into coagulopathy even after serial blood tests. So we came up with a recommendation of just a short period of observation, and the swelling is also self-limiting. Pain was never severe, so mild analgesia and discharge and TCA to come again if there's any other problems arising after discharge. So it's very conservative kind of management for a pit viper. Some people got a bit worried when it involves pit viper, but in Malaysia, I think in Singapore as well, and also Philippines, the pit viper from Tropidolemus is rather benign or mild, as you mentioned. Okay, so no indication for antivenom. There is no specific antivenom for Tropidolemus anyway. But the venomic study shows if you were to choose antivenom for Tropidolemus, then the hematopoly covers does have cross neutralization to the venom of the Tropidolemus. That's the lab study, okay? But it doesn't mean that we are using it for all patients because there's no indication for antivenom in all our cases that we studied so far. Okay. Right. Okay. So continue on, Melis. Just finish on what you watch for. Just to
So for
concur.
this species, the envenoming syndrome to watch for is essentially local, with increasing pain, progressive erythema, and progressive swelling. Then our recommended observation period is approximately 12 hours, and during which they monitored the progression swelling, the RPP serial examination, and repeated blood investigations.
Yeah, so regarding the repeated blood investigation from our studies as well, we are not suggesting for repeat antivenom, repeat blood tests anyway, because we know the results will be normal and patient will not go into coagulation. Okay, so that's why we, rather than wasting resources, we suggest just clinical observation. If there's no progression of painful progressive swelling, there's no need for you to repeat the blood test for the patient. Okay. All right. For this particular species, okay.
So after
Right.
approximately 5 hours, his pain had improved from 3 to 2. There was no progression of the swelling and no bleeding tendency. The heart rate had come down, blood pressure was normal, and the saturation remained at 99%. So the medical plan was to admit him to the open warm with lymph circulation and monitoring every 6 hours. Initially, it was to repeat the following morning, but I think the patient was discharged just after 5 hours.
Okay.
So to close with the key teaching points from this case, the correct species identification matters. So here we changed the recorded sex of the snake. Bites from this species are common in this part of Southeast Asia, but are rarely life-threatening. Severe systemic toxicity, major organ damage or death is very uncommon in healthy adults, and most bites resolve with supportive care alone, which is why we do not give any antivenom. So as I said, it usually causes local envenomation rather than systemic toxicity, and we should observe for progression over time rather than relying on single examination. And the short stay observation is appropriate once the patient is clinically improving, as we saw with this case.
Okay.
Thank you all, and I'm happy to take any questions.
Okay. Any questions from the floor?
Prof,
Yeah.
just want to ask also for this case and also the last case, how much does one wire cost, especially the vet?
It's, for us in Malaysia, we don't have any fixed price because it keep on fluctuating with currency exchange. We import from Thailand, right? Our antivenom for land snakes. So for the pit vipers and the cobras, they have two different preparation. One is a hematopoly, one is the specific ones for one species. I think the hematopoly is slightly more expensive, but I can't tell you how much exactly. Probably one vial is $100 per vial. So it depends on currency exchange. This will translate to how much we pay for each vial. Patient for one dose for the neuropoly and the specific for cobras and king cobras. The price, I mean, the first dose could be 5 vials to 10 vials, whereas the pit viper, the first dose is 3 vials. Okay, so yeah, treating cobras and king cobras with antivenom is more expensive compared to treating with treatment for pit vipers. Right. Do we have time for the next one? The short one? No. Is there a short case? No, no time. So we can close it. If there's no time, we can proceed with the next activity.
So if that's all, that concludes our case discussion for session 5, episode 4. Thank you to all our panelists, Dr. Jonathan, Dr. Vanessa, Dr. Patrick, and Dr. Hassan, as well as our advisor, Prof Khaldun, for sharing your expert opinions and valuable insights into the clinical management of toxin-related diseases throughout today's case discussion. We have prepared a quiz for the audience, so Prof Khaldun will share a Kahoot quiz shortly. Please scan the QR code or key in the PIN number to join the quiz. Prof has also prepared a big prize for the winner of the quiz, so try your best to score.
Okay. Number 3, Bevinda. Number 2, John T. And the champion is PH7.
All right, and once again, a very big thank you to all the panelists as well as Prof Khaldun for today's insightful sharing. I'll now pass on to the next moderator. Sorry for the technical difficulties. I'd like to invite Dr. Patrick for the closing speech. The floor is yours, Doctor.
Thank you very much for this wonderful event. The Southeast Asian Remote Envenomation Consultancy Services is very privileged to have this kinds of activities specifically for medical students. And I'd like to thank Dr. Khaldun for really putting this into the schedules of the students, and hopefully some of students as well will be able to join even the rest of the ASEAN countries. And hopefully the students are able to know something about clinical toxinology and its significance as a medical personnel, and how to manage these cases, which are not evidently been part of our curriculum. But with this, we are uplifting the standards of clinical toxinology, specifically in medical students, and hopefully you're able to adapt this as you go along with your career, and hopefully their learnings will be of importance, and not only in your practice but also be able to impart this to the rest of the medical community. Thank you very much.
Thank you for your closing speech. Before we end our webinar, everyone please turn on your cameras so we can take a group photo together.
All right. So, okay, thank you so much, Dr. Jonathan, Dr. Vanessa, Dr. Patrick, and also Dr. Hassan, as well as Prof Khal. Okay, I'll pass back to the moderator.
So we have come to the end of our webinar today. To all participants, please scan this QR code to fill in the feedback form to receive your e-certificate.
All right, so an announcement for Malaysian doctors who are joining us today. CPD points are provided. So do scan the QR code and feedback form. Do fill in the feedback form, and we'll register you to our administrative office for further credited to further credit your CPD points. Okay.
Once again, we thank you all for joining us today, and we hope you have learned something about clinical toxinology. And we hope to see you in the next episode of Clinical Toxinology. Is it relevant for medical students?
Thank you, everybody. Bye.
All right, thank you,
Thank you,
Prof. Thank you,
everyone.
doctors.
Thank you, Prof.